That bloating you feel after every single meal, the one you've learned to live with, the one you blame on eating too fast or stress or getting older, might be the first visible sign that your digestive system is failing in ways you can't see yet. I'm Dr. Michael Hayes, board-certified gastroenterologist, and in 18 years of clinical practice, I've watched thousands of patients dismiss chronic abdominal distension as normal discomfort. And by the time they finally seek help, we're not just treating bloating anymore, we're treating bacterial overgrowth, intestinal permeability, malabsorption syndromes, and in some cases, early stages of conditions that become much harder to reverse. Before we go further, quick disclaimer, this is educational content, not personal medical advice. Always consult your healthcare provider before making changes to your treatment. What I'm about to show you is what's actually happening inside your abdomen when that bloating occurs day after day, and why ignoring it could be costing you more than comfort. Margaret walked into my office on a Tuesday afternoon, 53 years old, executive assistant from Ohio, and she told me something I hear at least 3 times a week. Dr. Hayes, my stomach looks 6 months pregnant by 7 p.m. every single night. I wake up flat, I eat breakfast, and I'm fine. But by dinner, I look and feel like I'm about to burst, and it's been this way for 2 years. 2 years. 730 days of progressive abdominal distension that she normalized because it happened gradually, because her primary care doctor said it was probably just gas, because over-the-counter products gave her temporary relief, because she convinced herself this was just part of aging. She told me she'd stopped wearing her favorite dresses because they looked terrible by afternoon. She avoided dinner meetings with clients because she knew she'd be uncomfortable and self-conscious. She slept poorly because the pressure in her abdomen made it hard to find a comfortable position. And she'd started eating less and less throughout the day, trying to prevent the evening bloating, which only left her exhausted and nutritionally depleted. When I examined her and ran the appropriate tests, we discovered she had developed small intestinal bacterial overgrowth. Her intestinal lining showed signs of increased permeability. Her vitamin B12 levels were in the basement despite eating meat regularly. Her iron storage was depleted even though she wasn't having abnormal menstrual bleeding, and her body had stopped properly absorbing certain nutrients despite eating a relatively healthy diet. This wasn't just bloating. This was systemic digestive dysfunction that had been sending warning signals for 2 years, while she dismissed them as minor annoyance. Subscribe if you want more evidence-based guidance like this. I post every week. Here's what most people don't understand about chronic abdominal distension. Your abdomen shouldn't swell significantly after eating. That's not normal. That's not something that just happens with age. And it's definitely not something you should accept as your new reality. When your stomach and intestines are functioning properly, food moves through your digestive tract in an organized, efficient manner. Enzymes break down nutrients at the right locations. Bacteria in your gut maintain balance with beneficial species outnumbering potentially harmful ones. Your intestinal lining absorbs what you need and blocks what you don't, and gas production stays within normal limits that your body can handle without visible distension. Let me explain exactly how this process should work so you understand what's breaking down. When you eat, food enters your stomach where it encounters hydrochloric acid with a pH around 1.5 to 3.5, acidic enough to sterilize most bacteria and begin protein digestion. This acid bath is your first line of defense against bacterial overgrowth. It kills microorganisms that hitch a ride on your food and creates an environment where only your stomach's protective mucus layer and specific acid-resistant enzymes can function. From your stomach, partially digested food moves into your duodenum, the first section of your small intestine, where it meets bile from your gallbladder and enzymes from your pancreas. The bile emulsifies fats, making them easier to digest. The pancreatic enzymes break down proteins, carbohydrates, and fats into smaller molecules your body can absorb, and the pH shifts from highly acidic to slightly alkaline, creating the ideal environment for these enzymes to work. Your small intestine intestine, approximately 20 feet long and divided into the duodenum, jejunum, and ileum, is where the majority of nutrient absorption occurs. The intestinal lining is covered with millions of tiny finger-like projections called villi, and each villus is covered with even tinier projections called microvilli, creating a surface area roughly the size of a tennis court folded into your abdomen. This massive surface area is designed for maximum nutrient absorption, but it only works properly when the intestinal environment stays balanced. The bacteria that do belong in your small intestine are relatively sparse compared to your colon. We're talking about 10,000 to 100,000 bacteria per milliliter of fluid in your small intestine versus 100 billion to 1 trillion per milliliter in your colon. And the species that inhabit your small intestine are specific strains that don't produce excessive gas and actually help with digestion and vitamin synthesis. Your intestinal wall has its own nervous system, called the enteric nervous system, with more neurons than your spinal cord, and it coordinates wave-like muscular contractions called peristalsis that propel food steadily forward. These contractions occur continuously, but increase in strength after eating, moving food through your small intestine in 3 to 5 hours under normal circumstances. Between meals, your small intestine performs something called the migrating motor complex, a powerful cleansing wave that sweeps through every 90 to 120 minutes when you're not eating. This MMC acts like a housekeeper, pushing residual bacteria, undigested food particles, and cellular debris down into your colon where they belong, preventing them from colonizing your small intestine. But several things can disrupt this elegant, finely tuned system, and once disruption occurs, a cascade of problems begins. If you've taken multiple courses of antibiotics over the years, which many people have for sinus infections, urinary tract infections, dental procedures, skin infections, those medications don't discriminate between harmful and beneficial bacteria. They devastate your gut flora indiscriminately, killing off beneficial species that normally compete with and suppress potentially problematic species, creating an ecological void that opportunistic bacteria quickly fill. The recovery of your normal gut flora after antibiotics takes months to years if it happens at all without intervention, and each subsequent course of antibiotics makes the problem worse. If you have low stomach acid, which becomes increasingly common with age as gastric acid production naturally declines, which also occurs with chronic stress that redirects blood flow away from digestive organs, which is induced by proton pump inhibitors and H2 blockers that millions of people take long-term for reflux, your stomach loses its ability to sterilize food effectively before it enters your small intestine. Bacteria that should be killed in your stomach survive passage and begin colonizing your upper small intestine, particularly species from your colon that migrate backward when the acid barrier fails. Studies show that people on long-term PPIs have dramatically increased rates of small intestinal bacterial overgrowth, yet doctors continue prescribing these medications for years without addressing this consequence. If your intestinal motility slows down, which happens with diabetes because elevated blood sugar damages the nerves that control intestinal contractions, which occurs with hypothyroidism because low thyroid hormone slows all metabolic processes including gut motility, which results from certain medications like opioid pain relievers and some antidepressants and antihistamines, which develops with scleroderma and other connective tissue diseases. The normal sweeping motion that clears your small intestine becomes sluggish. Bacteria that should be pushed steadily downward into your colon start lingering in your small intestine, multiplying, forming biofilms on your intestinal wall, and establishing permanent colonies in places they don't belong. When bacteria overgrow in your small intestine, they do what bacteria do. They consume nutrients and produce waste products. They ferment carbohydrates you eat before your body can absorb them, producing hydrogen gas, methane gas, or hydrogen sulfide gas, depending on which bacterial species predominate. This gas production can be massive. Patients with severe SIBO can produce liters of gas daily, and that gas has nowhere to go except to expand your intestinal loops, stretching your intestinal wall, distending your abdomen visibly, creating pressure that radiates to your chest, causing reflux symptoms, symptoms: pressing on your diaphragm causing shortness of breath, pressing on your bladder causing urinary frequency, pressing on your back causing lumbar pain that gets misdiagnosed as musculoskeletal problems. But the gas and bloating, as uncomfortable as they are, represent just the tip of a much larger problem. Those same bacteria produce toxins including lipopolysaccharides, endotoxins that trigger inflammatory responses, D-lactic acid that can cause neurological symptoms like brain fog and confusion, and various other metabolites that interfere with normal cellular function. These bacterial waste products damage your intestinal lining directly, causing inflammation of the intestinal wall, disrupting the tight junctions between your intestinal cells that normally function like a security system, allowing nutrients through while blocking larger molecules, and creating what we call increased intestinal permeability or leaky gut. When your tight junctions loosen, suddenly things that should stay safely contained inside your digestive tract, partially digested food proteins, bacterial cell wall fragments, toxins, incompletely broken down nutrients, start slipping between your intestinal cells and entering your bloodstream. Your immune system, which is highly concentrated in the gut, with approximately 70% of your immune cells residing in gut-associated lymphoid tissue, recognizes these foreign molecules in your bloodstream as invaders and mounts an inflammatory response. This response isn't localized to your gut. These immune complexes circulate throughout your body, contributing to joint inflammation and pain that gets diagnosed as arthritis, skin inflammation that manifests as eczema or psoriasis or unexplained rashes, brain inflammation that causes cognitive dysfunction and mood disturbances, and increased risk of developing autoimmune conditions where your immune system becomes so hyperactivated that it starts attacking your own tissues. Meanwhile, because bacteria are consuming your nutrients before you can absorb them, because your damaged intestinal lining can't absorb properly even when nutrients are available, you can develop multiple nutritional deficiencies despite eating a seemingly adequate diet. Iron deficiency develops because bacteria consume dietary iron and because intestinal inflammation impairs iron absorption, leading to anemia, fatigue, weakness, cold intolerance, and impaired immune function. B vitamin deficiencies develop, particularly B12, which requires a healthy terminal ileum for absorption, leading to neuropathy with numbness and tingling in hands and feet, cognitive problems, mood disturbances, and megaloblastic anemia. Fat-soluble vitamin deficiencies develop when fat malabsorption occurs. Vitamin D deficiency contributes to bone loss and immune dysfunction. Vitamin K deficiency can cause bleeding problems. Vitamin A deficiency affects vision and immune function. Vitamin E deficiency causes neurological problems. Protein malabsorption leads to muscle wasting, low albumin levels, edema, and impaired wound healing. The consequences cascade and multiply, each deficiency creating new problems, each problem making others worse. Comment below, how long have you been dealing with daily bloating? Margaret's case illustrates this progression perfectly, but let me share another case that shows how different presentations can be while the underlying problem is the same. Robert, 47 years old, engineer from Texas, came to see me complaining primarily of chronic fatigue that had gradually worsened over 3 years. He mentioned almost as an afterthought that he also had bloating after meals, but his main concern was that he could barely make it through his workday without needing to nap. He'd fallen asleep during meetings. He had no energy to exercise anymore despite being an avid runner just a few years earlier, and he'd gained 30 pounds because he was too exhausted to be active. His primary care doctor had checked his thyroid and found it slightly low but not low enough to treat, checked his testosterone and found it slightly low but not low enough to treat, and ultimately suggested he was probably just depressed and offered antidepressants. When I evaluated Robert, his bloating pattern was similar to Margaret's. Flat in the morning, progressively distended throughout the day, but he'd lived with it so long he considered it normal and didn't connect it to his fatigue. Testing revealed severe small intestinal bacterial overgrowth with predominant methane production, significant deficiencies in B12, folate, iron, and vitamin D, despite supplementing with a daily multivitamin, and inflammatory markers that were elevated. His chronic fatigue wasn't depression, it wasn't just low thyroid or low testosterone, it was the direct result of his gut dysfunction causing malabsorption of the nutrients his body needed for energy production, causing chronic inflammation that made him feel like he had a low-grade flu all the time, and causing his gut bacteria to produce neurotoxins that affected his brain function. After treating his SIBO and healing his gut, his energy returned, his weight normalized, and interestingly, his thyroid and testosterone levels both improved on their own because his body finally had the nutrients it needed to produce hormones properly. These two cases demonstrate something crucial. Chronic bloating is never just bloating. It's always a sign that your digestive system is malfunctioning in ways that affect your entire body. And the longer you ignore it, the more widespread the damage becomes. Now here's where most people make critical errors in how they respond to chronic bloating, and understanding these errors will save you months or years of wasted effort and progressive worsening. Error number 1. They take over-the-counter gas relief products that provide temporary symptom relief without addressing the underlying cause. Simethicone products work by breaking up gas bubbles in your intestines, making them easier to pass, so you might feel less pressure and discomfort for a few hours. Activated charcoal absorbs some gas molecules, providing temporary relief. Digestive enzyme supplements might help break down some nutrients more efficiently, reducing fermentation slightly. But none of these approaches do anything to reduce the bacterial overgrowth that's producing the gas. None of them heal your intestinal lining. None of them restore normal motility. None of them address why the overgrowth happened in the first place. So you get a few hours of relief, sometimes not even that, followed by the same problem recurring as soon as you eat again, day after day, month after month, year after year, while the root dysfunction continues progressing unchecked, while your bacterial overgrowth worsens, while your intestinal damage deepens, while your nutritional status deteriorates, while your inflammation spreads. Error number 2, they severely restrict their diet based on random advice, eliminating entire food groups without understanding what they're doing or why. They read an article about how carbohydrates feed bad bacteria, so they go on an extreme low-carb or carnivore diet, which might reduce gas production temporarily, but also eliminates the prebiotic fibers that your beneficial bacteria need to survive, potentially making your microbial imbalance worse long-term. They eliminate all dairy because someone told them everyone is lactose intolerant, even though many people tolerate dairy fine, and eliminating it removes a significant source of calcium and other nutrients. They go gluten-free because they heard gluten causes inflammation, even though unless you have celiac disease or non-celiac gluten sensitivity, eliminating gluten doesn't help and restricts your food choices unnecessarily. They eliminate all FODMAPs indefinitely instead of using the low FODMAP diet as it's designed to be used, which is as a temporary elimination phase followed by systematic reintroduction to identify your specific triggers, and by staying on strict elimination long term. They're depriving their gut of the diversity of fibers it needs for health and potentially creating additional deficiencies. Random dietary restriction without proper testing and guidance frequently makes things worse, not better, or provides temporary symptom relief while allowing the underlying problem to progress untreated. Error number 3, they try random probiotics, buying whatever supplement has the most CFUs or the most strains or the best marketing, without understanding that probiotics are strain-specific and condition-specific. What helps one person might make another person worse, and taking probiotics when you have active bacterial overgrowth can sometimes feed the overgrowth rather than correct it. Error number 4, and this is perhaps the most dangerous, they normalize it. They tell themselves that everyone deals with bloating, that it's just part of life, that it's not worth bothering their doctor about, that it's not serious enough to warrant investigation. They accept progressively worsening symptoms as their new normal. They adjust their wardrobe to accommodate their evening distension. They plan their lives around their digestive symptoms. They stop eating foods they love. They decline social invitations. They suffer in silence because they're embarrassed, or because they think nothing can be done, or because previous doctors dismissed their concerns. I've seen patients who waited 5 years, 7 years, even 10 years before seeking proper evaluation. And by that point, we're not just treating bacterial overgrowth, we're treating severe malabsorption that has caused multiple organ systems to malfunction. We're managing profound nutritional deficiencies that have contributed to osteoporosis and neuropathy and cognitive decline. We're addressing chronic inflammatory conditions that have taken root throughout their body. We're working to heal an intestinal lining that has sustained years of continuous damage and may have developed permanent structural changes. The longer you wait, the longer recovery takes, and in some cases, the damage becomes only partially reversible despite optimal treatment. So what should you do instead? Let me give you the comprehensive approach that actually works, the same approach I used with Margaret and Robert and hundreds of other patients who are now living without daily bloating and with restored health. First, understand that chronic daily bloating, the kind where your abdomen visibly distends after meals and stays that way for hours, where you can measure a difference of 3 to 6 inches in your waist circumference between morning and evening, where the discomfort is predictable and persistent, where it's been happening for months or years. This requires proper medical evaluation. This is not something you should try to self-diagnose and self-treat indefinitely. You need to see a gastroenterologist who understands functional digestive disorders and who can run appropriate testing to identify what's actually wrong. Breath testing for small intestinal bacterial overgrowth is non-invasive, relatively inexpensive, and highly informative when performed and interpreted correctly. The test measures hydrogen and methane gas in your breath after you drink a specific sugar solution. If bacteria are overgrowing in your small intestine, they'll ferment that sugar and produce gas that gets absorbed into your bloodstream and exhaled in your breath. And the timing and pattern of gas production tells us where the overgrowth is located and which type of gas-producing bacteria predominate. Comprehensive stool analysis can reveal information about your gut microbiome composition, whether you have adequate digestive enzyme production, whether you're properly digesting fats and proteins, whether you have markers of intestinal inflammation, whether you have beneficial bacteria at appropriate levels, and whether potentially pathogenic organisms are present. Blood work should include complete blood count to check for anemia, comprehensive metabolic panel to assess organ function, iron studies including ferritin to evaluate iron stores, B vitamin levels, particularly B12 and folate, vitamin D levels, inflammatory markers like C-reactive protein, and erythrocyte sedimentation rate, thyroid function tests because thyroid problems can slow motility and contribute to bloating, and celiac serology if you haven't been tested before because celiac disease can present with bloating and needs to be ruled out. In some cases, upper endoscopy with small bowel biopsy may be necessary, particularly if celiac disease is suspected, if you have alarm symptoms like unintentional weight loss or bleeding, or if initial treatment fails and we need to look directly at your intestinal lining to see what's happening. Once you have proper diagnosis, treatment becomes targeted rather than random, and this is where comprehensive approach becomes essential because treating just one aspect of the problem doesn't work. If bacterial overgrowth is confirmed, antibiotic therapy is typically the first-line treatment. Rifaximin is the most commonly used antibiotic for SIBO because it stays in the gut rather than being systemically absorbed. It has minimal side effects. It doesn't typically cause the kind of dysbiosis that other antibiotics cause, and it's effective against a broad range of bacteria that commonly overgrow in the small intestine. The usual course is 550 milligrams 3 times daily for 14 days, though some patients require longer treatment or combination therapy with other antimicrobials depending on their breath test results and symptom pattern. For methane-predominant SIBO, which often causes more constipation than diarrhea, rifaximin is often combined with neomycin or metronidazole because methane-producing organisms respond better to combination therapy. Some patients respond well to herbal antimicrobial protocols as an alternative to antibiotics. Combinations like berberine, oregano oil, neem, and other botanical antimicrobials have been studied and shown comparable effectiveness to rifaximin in some trials, and these can be good options for patients who prefer to avoid antibiotics or who haven't responded to antibiotic treatment. Emerging research shows that elemental diets, which provide nutrition in pre-digested form that gets absorbed in your upper small intestine before bacteria can ferment it, can effectively starve out bacterial overgrowth while maintaining your nutrition. This approach requires drinking only elemental formula for 2 to 3 weeks, which is challenging but can be highly effective for difficult cases. But here's what's absolutely crucial. Antibiotics or antimicrobials alone are never sufficient as standalone treatment because if you don't address why the overgrowth happened in the first place, it will recur within 3 to 12 months in the majority of patients. Your bloating is accompanied by yellowing of your skin or the whites of your eyes. This indicates jaundice, which suggests liver or biliary problems, or if you develop new onset swelling in your legs and abdomen, this could indicate liver disease with ascites or heart failure. These require urgent medical evaluation. For women, if you have a family history of ovarian cancer and you're experiencing new onset persistent bloating, particularly if accompanied by pelvic pain, feeling full quickly when eating, or urinary urgency, these are the subtle symptoms of ovarian cancer, which is often diagnosed late because symptoms are vague. You need evaluation by your gynecologist with appropriate imaging and tumor markers, not just dismissal that it's IBS. The information I'm sharing is meant to complement medical care, not replace it. Individual results vary based on the specific causes of your bloating, severity of your condition, how long it's been present, other underlying health issues, and how consistently you implement treatment. And what works perfectly for one person may need modification for another based on their unique situation. For the vast majority of people dealing with chronic daily bloating without alarm symptoms, the issue is functional digestive dysfunction, most commonly small intestinal bacterial overgrowth or related conditions, rather than emergency or malignancy. But proper medical evaluation is essential to make that determination safely and to identify exactly what's causing your symptoms, so treatment can be appropriately targeted. You cannot and should not try to diagnose yourself based on symptoms alone, or based on information from the internet or from well-meaning friends. What you can do starting today is stop normalizing daily abdominal distension, stop dismissing it as just gas or just aging or just something you have to live with. Recognize it as the warning signal it actually is, the visible manifestation of internal dysfunction that's affecting more than just your comfort, and take action to get proper evaluation and treatment. The path from chronic bloating to normal, comfortable digestion is longer than you'd like. It requires commitment and patience, but it's absolutely achievable. And the alternative, continuing to suffer while your gut dysfunction progresses and creates more widespread problems throughout your body, is not acceptable when effective treatment exists. If this helped, 3 things. Hit like so more people find this information, subscribe for weekly digestive health content, and share with someone who's dealing with chronic bloating. Comment committing to one change you're making this week, whether that's scheduling an appointment with a gastroenterologist, eliminating snacking between meals to support your MMC, or starting a food symptom journal to identify your patterns. Those 4 actions take 30 seconds but could change everything.